Good afternoon, everybody. We had more than 150 registrations from across the world. I know this time is not optimal for several time zones, so we're really excited to see a lot of our partners from across the network who are joining this webinar. I'm just going to give everyone a couple of minutes more to allow them to dial in, and then we can get started. Okay. Hello, everybody. I'm delighted to welcome you to this inaugural edition of the APMEN Exchange. APMEN, as several of you know, is a 10-year-old institution, and it has significant technical expertise that resides within its members, whether they are national malaria programs or partner institutions who are implementing malaria interventions, conducting research, supporting capacity strengthening. So one of our key objectives at the APMEN Secretariat is to provide a platform to facilitate the sharing of experiences among partners, the sharing of real life stories from the ground on what has worked and what hasn't, and really to strengthen our collective understanding of best practices on the road to malaria elimination. So this initiative, the APMEN Exchange, is a virtual initiative that we hope will facilitate some of these conversations in the months ahead. When the COVID outbreak hit us earlier this year, there were a lot of questions around what this means for malaria in the region. From a case management perspective, we know that like malaria, one of the most common symptoms of COVID-19 is fever. So what should our guidance be to community healthcare workers? How do we protect individuals who are seeking care at health facilities? Coming to malaria treatments, we now know that chloroquine and hydroxychloroquine may have potential application for COVID-19 treatment. So then the questions are, what does this mean for access to these drugs within malaria programs? And then there's the issue of vector control interventions. At a time when physical distancing is being recommended everywhere, how do we continue bed net distribution and indoor residual spraying? Fortunately, we have the right experts on this webinar today who can provide some guidance and context on how to sustain malaria service delivery during a pandemic. I'm delighted to welcome from the WHO, Dr. Nina Valecha, Regional Advisor for Malaria at WHO's Southeast Asia Regional Office, and Dr. James Kelly, Technical Officer, Malaria Surveillance and Elimination at the WHO Western Pacific Regional Office. Dr. Nina is the former director at the National Institute of Malaria Research, the only research institute in India that's devoted to malaria research. And she has over 30 years of research experience in malaria, including around drug resistance, designing and conducting clinical trials for malaria, diagnosis and treatment of malaria, and pharmacovigilance. Welcome, Dr. Nina. Dr. Kelly provides technical support to WHO member states in the Western Pacific region for accelerated malaria control and elimination. He is currently coordinating elimination support to the 3 WHO E2020 countries in the Western Pacific, including China, Malaysia, and the Republic of Korea. Welcome, Dr. Kelly. And finally, we're very fortunate to have with us today Dr. Rose Nani from Malaysia's Ministry of Health. Dr. Rose is a public health physician and has extensive experience with Malaysia's vector-borne disease sector, which she currently leads within the Disease Control Division. So welcome, Dr. Rose. A few housekeeping announcements. In terms of the format for today's webinar, each of our 3 speakers will present for around 10 minutes each, followed by a moderated panel discussion for 15 to 20 minutes. We're then going to open up for question and answers from the audience at the end, and encourage participants to use the Q&A box at the bottom of your screens to share your questions. If your questions are to a particular panelist, please mention that in the question as well. So with that, I'm now going to invite Dr. James and Dr. Nina to share their perspective on maintaining malaria operations in the context of COVID-19. Over to you, Dr. Meena.
Thank you, Amita, for those kind words, and good morning to all. And I really appreciate organizers for arranging this, connecting all of us during this crisis, used remotely using all the digital technology. So I have my colleague James Kelly with me, and so jointly we'll be addressing the topic of maintaining malaria operation in context of COVID-19. Can I have next slide, please? Next slide, please. Okay, so as you all know, in January 2020, a novel coronavirus caused outbreak of viral pneumonias, and it was declared a public health emergency of international concern on 30th January. The countries are, engaged in slowing the spread of disease because it is a highly transmissible disease, and there is mortality also in the vulnerable groups like elderly and those having comorbidities. So naturally, the countries are trying to manage to provide care to COVID-19 patients, managing the mortalities, and also the health systems are overstretched. So there is need to minimize the impact on the health systems, and it varies from country to country, but we have seen all over the globe the crisis which the countries have faced during this time. But when we talk about malaria, I mean, the Ministries of Health and NMCPs, they need to ensure that malaria control efforts are not hampered during this crisis. And also we don't know how in malaria endemic countries the risk to COVID will shape up, because we have not seen as of now the many COVID cases in the region which is endemic to malaria, and now we start seeing the surge of cases. Next slide, please. Can I have the next slide? Thank you. So let me start with the malaria situation in the globally and in the region. So globally, there were 228 million cases in 2018, according to World Malaria Report, and of course, 93% being from Africa region. So although the progress has been stalled recently in the recent past, but still the number of countries with fewer than 100 indigenous cases increased from 17 countries in 2010 to 25 in 2017 and 27 in 2018. When we talk about Southeast Asia, the estimated cases were 7.9 million in 2018, and 3 countries contributed to the most of the cases, and that being India, Indonesia, and Myanmar in the region. But there has been a lot of progress in this region. Specifically, you can see the case incidence rate dropping. You can see the green line here. And the reduction of 69% and 70% in estimated cases and mortality was seen as compared to 2010. So this is the region which showed the largest decline. But there are other specific issues also, like almost half of the global Vivax burden is in this region, which also poses a challenge, and majority cases being from India. And out of the 11 member states, you all know Maldives and Sri Lanka continue to be malaria-free, while Timor-Leste did not report any indigenous case since 2017. So those are the positive signals, and we need to retain that gains. Next slide, please. So malaria in Wipro region will be taken up by James when he makes the presentation. So I'll skip that from here. So why we should be worried? So as I mentioned, that health systems are overwhelmed, and because it is the direct mortality from the epidemic, but also the mortality from the treatable and other vaccine preventable diseases which can increase. I mean, not only malaria. And we have seen from our experience during Ebola outbreak that although there was mortality due to Ebola, but there was increased deaths due to much more than Ebola outbreak itself, due to measles, malaria, HIV, and tuberculosis, because the health system failures were there. They were not, the countries were not able to manage the other services, and that led to rather more people dying due to other diseases which could be prevented otherwise. And similarly, recently a modeling exercise was done for sub-Saharan Africa, which showed that if there, in the worst case scenario, if the BedNet campaigns are suspended and there is 75% decrease in access to the treatment for malaria, the malaria deaths could double as compared to 2018, which is really alarming. So we have seen that most of the countries are facing challenges which are quite common, but the degree may vary according to the situation of COVID and the malaria endemicity. But definitely, universally, the movement restrictions due to lockdowns, the restricting the health worker movement, and also the supply issues. So these are of variable degree are being faced by countries. Of course, a major issue is coming up is the safety concerns for the frontline workers. They are themselves worried, and then even in the authorities. So there is a lot of issues of, and we have seen, globally about 10% of cases are from the health worker settings, different categories of health workers, which has been seen, who have been infected. And also, although the services are continuing, I'll go into the detail a little later, but definitely the face-to-face training programs, especially being conducted at the peripheral level by the country program, they are definitely disrupted, although countries are resorting to alternate means. And of course, James will explain it further, but the BedNet campaigns and the IRS are being also delayed, or in some places it has been disrupted. So it's not universal everywhere, but the degree varies. But these are the general issues which are coming up, the countries are facing. Next slide, please. So when we talk about the need of service provisions for malaria prevention and diagnosis and treatment, now why we say so? Because we know for COVID, there is no specific treatment as such, and it is the supportive treatment and managing the patient in intensive care. But for malaria, we know it can be diagnosed immediately, it can be treated effectively. So we should not delay this effort, and we should not these efforts should not be hampered, and we should ensure that a disease which is preventable, which can be diagnosed, which can be treated, should be immediately managed. And also, as I mentioned, like severe anemia due to malaria, or as it is a patient having malaria and COVID, so how the risk of each of the disease is increased or not, we have no information as of now, but gradually the WHO has initiated efforts on getting case reports formed and other things, so that we will know that what is the clinical presentation in these malaria endemic countries. And of course, as I mentioned, that there has been progress in some countries, and especially in the Southeast Asia region, and these need to be retained. And also the countries where malaria has been eliminated or about to be eliminated, they need to really sustain their intensive surveillance and also the vector control activities, so that we don't lose those gains. And of course, there are many things which need to be overcome like travel restrictions and maintaining logistics and supply chain, in addition to the other technical issues related to the disease. So actually, the best practices for prevention and control need to be followed. And there are recommendations from WHO. But, if there are so many other issues related to logistics, availability, resources, so the countries need to adapt to the local need. And countries have been trying to do that. I'm just happy to share that. Can I have next slide? So there, as I mentioned, there are guidance documents which have been developed, and one of that is tailoring malaria interventions, and also the operational guidance on maintaining essential health services. And recently there is a guidance document on community-based health care. So these are the general guidelines. It gives the broad outline and also the nitty-gritty on how to manage at community level. But again, I say that it needs to be adopted according to the local situation. And one more issue is that we are getting more and more knowledge or getting to know more about COVID. Every day there is new information. So definitely the situation is dynamic, and the guidance and documents are also, WHO is trying to update them regularly and also give information in form of Q&A, because, guidance has to be dynamic according to the situation of COVID and according to the new knowledge which we are gaining from various countries across the globe, whether it is the management or treatment or vaccine updates. So much information is there. So these documents are being accordingly, or the information is being updated. Next slide, please. So we are talking about addressing endemic malaria and COVID-19 in the countries where we have malaria endemicity. So the guidance from the tailoring malaria intervention is that, of course, we need to have a rapid response to manage malaria cases and patients. But there has to be flexibility for that, because as I said, one has to adapt according to the evolving COVID situation. It's not that in one country, all over there will be similar situation with COVID or similar situation with malaria. So one has to see the dynamics, and accordingly the ministries need to organize themselves. So the purpose is basically the protecting healthcare workers as well as the patients. Not only for disease, but protecting from COVID as well. So the one needs to continue to provide services, but for that, some efforts or some intervention need to be there. First of all, the malaria focal points or in the programs, they need to have continuous engagement with the COVID-19 stakeholders and also the National Task Force, and also the activities which are ongoing, because this will help them to know the risk of COVID in particular area where they are managing cases, and accordingly they can manage direct their healthcare workers or educate them. Of course, when we are talking about COVID-19, and you have heard that during the lockdown, the clear message is stay home. So, and of course, the different categories of quarantine and isolation are practiced by countries. So, but for malaria, the feature should be that the person should immediately seek care for fever, for diagnosis and treatment. So that messaging has to be very clear that in the malaria endemic areas, if there is fever, the person needs to be diagnosed for malaria. So that message at community level has to be clear, and one should not get confused that when there is a message that stay home, so it means that even if there is fever, one should not seek diagnosis. But that needs to be clarified to the community through community leaders and otherwise the messaging. And of course, the case management services, the access has to be there, whether it is at the household level by community worker or at the health facilities. One has to adapt according to the local situation of COVID and how much is the risk involved. And also we say that there should be minimum interaction between the health worker and the whatever activities to be done should be in the minimum time. So RDTs would be better rather than person coming for microscopy and waiting for results and then at the health facility. So the RDT can be immediately done. It's quite sensitive. So that is preferred, so that there is minimum interaction. And of course, the treatment of confirmed cases according to the national guidelines. And like Amita raised here, that in some countries, for prevention of COVID or otherwise for treatment, chloroquine, hydroxychloroquine are being given. So one has to be very careful if the patient is taking those medicines, and the health worker or at the facility level, one needs to be very careful that what medicine the person is taking for COVID infection, and accordingly decide the safety of the antimalarial medicine. Next slide, please. So the core structures are existing for malaria, but they need to be strengthened. As I mentioned, that NMCPs need to be very much part of the task forces for COVID to have all the information related to that. And as regards the supply chain and logistics, we discuss later as well. But definitely the one has to anticipate the need. There may be increased demand because of fever being the symptom for COVID as well. And also the logistics, there may be delays in supply, so one needs to have stocks in advance and estimate the needs in advance. So those NMCPs should be very clear about this, and also the reporting issues which could be disrupted, or there could be a problems and there could be modified case definition. So this, one should not have the impact on epidemiological trends due to the disrupted information systems. So that needs to be taken care. And of course, as I said, the community engagement and communications are very important, so that the correct messages and correct care-seeking behavior is there with the community. Next slide, please. So when it comes to specifically for case management, now that, as I said, the risk needs to be minimized. And of course, when we say the generic term that we need to take the droplet precautions, but like if we want to specify, the situation would be different. But like if it's a home visit by a healthcare worker, the advice would be that it could be, if possible, outside in a well-ventilated area rather than going into the house. And going into the closed space. And of course, the hand hygiene and is to before, if the contact with the patient and after contact with the patient, hand hygiene has to be there. As we say, the health worker and patient both need to be protected. And of course, the droplet infection care needs to be taken. And if there is a direct contact like RDT or doing RDT or direct exposure to body fluids, gloves should be there, and also the mask if distance cannot be maintained, and we say social distancing as far as possible. And also for the when we are saying that the patient, whether they should be very clear that what is a suspected case, and if the case is they are dealing with a suspected COVID case, they have to have protection measures accordingly. And if it is not a suspected case, then the protection, because we have to rationalize the use of protective equipment as well. So availability is not unlimited. So you can't use everything everywhere. So one has to see in which situation what is needed. And if so we need to, as I said, motivate the health workers, give them the enough right kind of supplies for hand hygiene, and if it is a facility, the hand washing stations should be there. And also these facilities need to be supervised at how the infection prevention control is being managed by district level officers, so that the health facilities are managed properly. So as I mentioned, so these are the at the ground level, the activities which are needed, and the education is needed, in addition to the provision of the supplies, the RDTs, whether it's the treatment courses, and also the continuous motivation of health workers, and so that they remain connected. They have, some countries have the required apps on their mobile phone, so that they are constantly getting better information, and that boosts their morale also. And then, as I said, their health checkups, and of course, according to the local policies and availability and resources, the protection has to be there. And of course, James will be talking about the campaigns and other exposure. But if the health worker has to go to a household for one activity, rather than different activity, rather than going 3 times, it could be clubbed into one, so that the minimum exposure is there. And also, when the patients are going to a health facility, those which are suspected or having the symptom, they should be separated from the others who are coming for chronic illness treatment. And also that information and education should be there, so that these are dealt with in separate areas, so that the exposure of between patient, different type categories of patient is also not there. And also the patients who have both COVID and malaria, as I said, then again you need to go back to the national policy, and many countries have issued their local treatment guidelines for the country, so which is very useful, and so that they can be adapted. Next slide, please. So this is my last slide, although I don't want to give a message here that these are the measures should be taken. That's why we are saying extraordinary measures. So in the normal circumstances, what I mentioned is you diagnose and treat according to the national policy. But in some situation, which at the moment we don't see in, at least in Southeast Asia region, but if the situation arises, as I said, it is dynamic, and that time there could be a consultation within the country, say whether presumptive treatment, like without diagnosis, whether treatment needs to be given. Now, supposing there are no RDTs available, health workers are not there, or who can do the testing, or in those situations, fever case could be treated for malaria without diagnosis. And similarly, for giving the mass drug administration, although this term is very much misused many times, but it has happened like in situations like Ebola, where there was high mortality due to the disease, and malaria was also endemic. So in those areas, the treatment for malaria was given to those all fever cases so that the healthcare workers are not exposed. So those are very specific situations. If need arises, the countries can debate and then accordingly work, because one has to consider the requirement of the health workers education on this, and then the availability of commodities which are already in short supply in many areas. So we should, and also the side effects and the other issues. So these are not the measures which should be taken just like that, but in case the need arises with specific consideration and safety measures, these could be taken. So now I hand over to James for his discussion on the continuity of vector control services. James, please, over to you.
Okay, thank you, Nina, and good afternoon to everyone. It's good to be here. I think it's a timely presentation. Yeah, to briefly summarize first the malaria situation in the Western Pacific region, the most recent estimated number of malaria cases was around 2 million, although confirmed cases were closer to 700,000. And similar to Sierra, only 3 countries accounted for 98% of total burden, including Papua New Guinea, Cambodia, and Solomon Islands. Although confirmed cases increased 8% over the last 8 years, the good news is that malaria deaths decreased over 72% since 2010. This really demonstrates how primary care coverage and services have improved across the region. So while much progress has been made to dramatically reduce falciparum malaria in the GMS, there is still the issue of drug resistance and a threat to achieving elimination. And a note of success is that of the 10 member states in the region, China and Malaysia have reported 0 indigenous malaria cases since 2017 and 2018, respectively. Next slide, please. So really, many of the recommendations and how-tos for maintaining vector control interventions in the context of COVID-19 align very closely with what Nina has already established when she has presented on case management. She's also emphasized that although WHO has developed these guidance documents, countries should always contextualize to the local situation. As countries and ministries of health have had to reprioritize activities and divert staff to pandemic preparedness and response efforts, I'd just like to emphasize how important it is for the malaria program's leadership to advocate to other health and non-health leaders in government on behalf of malaria patients and most at-risk populations in the country, to really ensure not only for vector control activities, but all malaria services continue to the greatest extent possible. So for the next couple of slides, I'll highlight some of the key aspects around what programs should consider during vector control interventions. But as Nina has highlighted, please do refer to the WHO document, Tailoring Malaria Interventions, for more comprehensive details. The first point, of course, again, emphasizing that the safety of community members healthcare staff, and service delivery teams needs to be ensured while continuing to implement the core vector control activities. To prevent the spread of COVID-19, program staff, community members involved in the field interventions, including ITN, LLIN distributions, indoor residual spraying, and some entomological surveillance activities, should follow the proper infection prevention and control techniques. You know, this includes the basic stuff that we've been hearing over the last few months, the hand washing, the social distancing, etc. So as the community level, at the community level, this really will include briefing and engaging the community leaders and individual community members before and whilst intervening in those communities. Also, to maintain vector control services, just as Nina has noted around case management, staff must be able to overcome travel restrictions, meaning possible exceptional approvals from the ministry supervisors and/or other senior leadership. And the staff on the ground really should carry along travel approval documentation and COVID testing results to present to community leaders so they are confident to allow intervention staff into the communities. Next slide, please. So regarding ITN and LLINs, WHO currently recommends that the current and planned campaigns should go ahead if at all possible, of course, with additional measures to prevent COVID-19 transmission. Before net distributions each day, the program may consider to send reminders through social media or group chats to all registration and distribution teams to wash their hands with soap and water, seek care if sick, and avoid physical contact. Temperature checks could be reinforced for all intervening staff where feasible. Countries will have already prioritized stratification for ITN and LLIN distributions based on the malaria burden. Although this planning should be respected, in some cases in urban areas with dense populations, they may have higher risk of person-to-person exposure to COVID-19, but lower rates of malaria infection. So if needed in these areas, they could be deprioritized for ITN distribution compared to rural settings with higher malaria transmission. Also, during fixed site distributions, the program and the communities can consider organizing this in a way that minimizes the gatherings of people to maintain social distancing. And some adaptations can be made to the normal procedures to reduce the risk of person-to-person contact, such as suspending some data and accountability procedures, such as signing each household member or each household signing for nets received. Next slide, please. Indoor residual spraying. WHO recommends moving forward with current and planned IRS campaigns, but again, ensuring incorporation of proper infection control and prevention. Additionally, all spray team members should be issued and should wear N95 masks if available, or other types of mask, and of course, other routine PPE. Vehicle passengers should be limited to one team at a time, and then breaks, meals, and IRS cleanups can be maybe staggered to allow for more physical distancing. Moreover, it would be beneficial to the communities if clear instructions are given to families to also practice physical distancing from their neighbors while evacuated from their homes. Finally, daily pre-spraying community sensitization campaigns, such as the importance of maintaining social distancing, should be reinforced with preventive measures related to malaria and COVID-19. Okay, final slide, please. So unlike the ITN and LLIN distributions and the IRS, WHO is now recommending temporarily suspending most routine entomological surveillance activities until COVID-19 transmission wanes, including vector bionomics monitoring, IRS durability monitoring, and non-routine entomological monitoring. Of course, again, as Nina has emphasized as well, this really depends on the context and should be considered and reevaluated depending on the COVID-19 situation. Where activities can be implemented then safely, then there's no reason why they should be delayed. However, if it is a COVID situation, exceptions can be made when there is little to no risk. One of those exceptions is that insecticide resistance testing can continue, but really, if only using mosquitoes reared from larvae and not adult collections in the field to minimize person-to-person contact. Second, IRS spray quality and residual efficacy monitoring can continue, but should be limited to initial wall cone bioassays to assess spray quality. Subsequent monthly bioassays should be suspended until the situation warrants reevaluation. Third, efforts should continue to maintain mosquito colonies while adhering to additional infection control precautions. Finally, I just want to emphasize that, of course, the COVID-19 situation is evolving, and each country in our region has unique malaria and COVID situations. As such, each country can and should evaluate its risk frequently and update its malaria interventions as the situation evolves. On the same side, WHO is sort of treating these guidance documents as live and evolving documents. They are also being updated continually. And really, the main point here is to continue essential services whenever possible to prevent the resurgence of malaria. That's the most important message I'd like to leave. Thank you.
Thank you, Dr. Nina, and thank you, James. A very valuable presentation. We'd now like to hear from a National Malaria Program that's actually really living and managing this crisis. So Dr. Rose, over to you.
Yeah, thank you, Amita. Good morning, good afternoon, good evening to Amita and the panelists and also the webinar audience. Congratulations. I would like to take opportunity. Congratulations to Edmund for organizing this webinar. And can we move to the next slide, please? Okay, this will be the contents of the presentations. Consists of 5 big topics on the topics that given to us. Challenges of malaria services delivery during COVID-19. Next slide, please. So when COVID-19, which earlier was known as a novel coronavirus, started to begin reported to WHO in January 2020, and China was the main country affected by this disease. Malaysia started reporting imported cases from China on 25th January. So, and there was no local transmission yet during that time until late February 2020. And Malaysia officially or enforced Movement Control Order, MCO, starting on the 18th March 2020. So when the MCO was enforced, it's actually giving rise to economic implications, services delivery, and psychosocial implication to public, and including our healthcare workers. So when the MCO implemented, firstly we felt uncertain, and many questions arise from the program managers and also the ground staff with regards to how long the MCO will continue. Will we be able to continue with the control activity? Are we allowed to move from one area to the another area? And we were also worried of getting the COVID-19 infections if we are doing the control activities. And the MCO continues till today in Malaysia, with now progressing to conditional MCO, which is less stringent allowing more control activities and areas can be carried out. And as of 13 May, Malaysia has reported a total of 6,779 COVID cases with 111 deaths nationwide. Next slide, please. Next, all right. The vector-borne disease program at all levels, from districts to national levels, continue doing malaria surveillance without disruptions during COVID-19 pandemic by the dedicated team and staff at all levels. From our surveillance, we noted there is a declining trend of all malaria types during MCO periods. Next slide, please. On the 10th of April, 2 weeks after the MCO enforcement, the vector-borne disease program issued a formal administrative order on critical actions that need to be done for malaria control by the ground staff. So these are the letters that released. It was issued by our Deputy Director Generals of Public Health. Next slide, please. The basic principles of the administrative order are prompt actions in the control of malaria cases and outbreak, house-to-house distributions of long-lasting insecticide nets to avoid community gathering and maintain social distancing. Key malaria commodities supplies such as diagnostic equipment and anti-malaria medicines are not interrupted. So, and malaria screening among high-risk groups also continues. But we do have to innovate on the malaria prevention strategies during the MCO by modifying critical actions on the field for malaria preventions. The critical activities for malaria control is tailored in line with the COVID-19 zoning and standard operation procedure. So if you can see in the slides, for example, the COVID-19 zoning is classified in green, yellow, and red based on the number of active COVID-19 cases. So green is 0 cases, yellow is 20 to 40, and red is more than 40 COVID cases. The critical malaria activities are carried out in all zones. Example, if you see the color coded on the COVID zone in the slides. Example, passive and active case detection with COVID-19 precautions such as practicing distancing and wearing face masks and frequent hand washing by the malaria ground staff. So there are some activities that continued, for example, case detections. Certain non-critical activities are deferred. Example, active case detections in a clear malaria foci. So you can see in the slides. Next slide, please. So vector control method is modified for IRS to distribution of LLRN house to house without mass community gathering. So previously we do IRS. However, we need to modify our control measures to delivering LLRN during the COVID pandemic. This delivering of LLRN is from house to house, so we avoid of any community gatherings. Usually we gather all the community and we distribute the nets, but during the pandemic we go house to house and applying all the COVID-19 precautions, preventive precautions by our health staff. Next slide, please. So in view of the COVID-19 pandemic, the World Malaria Day of 2020 observance was modified without national launch. Messages and campaigns on World Malaria Day via electronic and social media. An official press release on the World Malaria Day 2020 was issued by our Director General's Ministry of Health, Malaysia. Next slide, please. Next slide. Next slide. So moving next slide, please. So moving forward, Malaysia has come out with the post-COVID-19 standard operation procedures in line with the new normal concepts. The new normal SOP is still based on COVID-19 zoning with taking precautions on the COVID-19 preventions. In summary, next slide, please. All malaria activities will continue to be implemented except in specific locality declared as enhanced MCO, which require total movement control. So these are the activities that will continue. However, we have to modify it. For example, for meetings, we need to use our online or Zoom meetings or any social, like using if any discussion, we use like WhatsApp or email. And for activity like our nationals at the nationals operation room, the national operation room is still operating, but however we are practicing the standard precaution for COVID-19 for all our staff in the operations rooms. Next slide, please. So in the if you see the green, the yellow, and the red arrow is based on the zoning that in line with the COVID-19 standard operation procedures. So there are some activities that will continue, but we modified the methodologies of doing the prevention methods. And another slide, next slide, please. Next slide. Yeah. For the field supervisions, it's at the area where there are no longer COVID cases reported, it will go on as usual. But for area which have with the enhancement of movement control order, we will defer the activities. Next slide, please. So so in the outbreak area or in the case area, all the activities, for example, case detection, treatment, and follow up, and will be carried out by our staff, and they are also practicing the standard precautions for COVID-19. Next slide, please. The challenges, in summary, the challenges of malaria service delivery during COVID-19 is, of course, with the movement control order, it actually limits the movement of our health staff to malaria service delivery, and also limits the movement of individual or community to access health services. And the other challenges is interruptions of services delivery in the community, where we are unable to enter the house and unable to conduct the control activities, example IRS. But we have to modify our control measures to delivering of LLRN. And there were no mass gathering allowed in the community. So so this is also where we have to modify the way we deliver our bed nets to the community. And the other challenges is mitigating risk of COVID-19 infection to our vector staff. So we need to convince and advise our vector staff what are the universal precautions in the COVID preventions, and they should practice it and they should apply when they are at the ground doing their work. Mitigations of physiological distractions among our health staff, we need to convince our ground staff and give a proper advice to them and clear instructions. And that's why we came out with the administrative order in April, so that our ground staff know what to do and what not to do. And we also having challenges competing for the priority with COVID-19, especially for resources, budget, and logistics. And I think globally, the shortage of PPE supply is also happened in Malaysia in the beginning, but however, is already overcome by our ministry. Dynamic COVID-19 epidemiology and MCO instructions from the government also influencing our activity at the ground. So we need to be alert if there's any changes in the COVID-19 standard operation procedure from time to time. Next slide, please. So way forward, strong program leadership at the national level is important, and critical intervention for malaria control must continue during MCO. Disease burden stratification for malaria and COVID-19 are important to harmonize the critical intervention for both diseases. For effective planning, the program requires continuous updates of COVID-19 situations. For example, the epidemiology, the mode of transmission, control and prevention, and guideline and SOP of COVID-19. For effective implementation of critical interventions on the ground, health staff must to be updated and convinced on the safety measure. Electronic and social media are the best platform for communication in pandemic situations. And malaria program must adapt to the new normals in the malaria control. In pandemic situations, the program must use innovative methods in delivery of services for malaria. Next slide. Next slide. So this is the pictures of the event that happened in our country. So our Director General will give daily update on the COVID-19 situations. This is also happened with our Ministers of Defense, which they are giving a daily press conference to our to the publics. And another also message from our Prime Ministers on the COVID-19. So I think at the ground we have a picture of enhanced movement control order. If you see all the wire there all around with the army is controlling. Guarding the area where the EMCO is enforced. And of course, our frontliner is working very hard day and night to take care all the COVID-19 patients. We have also the army and the police and other ministry is helping Ministry of Health in combating the COVID-19 pandemic. Next slide. I think that is the end of my presentation. Thank you very much.
Thank you, Dr. Rose. That's a really very comprehensive overview, I think, of the plan that Malaysia has put in place, and just this sort of scale and scope that you've laid out is really very ambitious and provides a blueprint, I think, for a lot of other countries in the region as well on how best to manage this. I'm going to sort of now invite everyone onto our virtual panel, as it were. Chris, maybe you can stop sharing the slides so that the participants can see all three us panelists on the screen. I know that James needs to leave, so I'm going to direct a couple of questions to him first in the interest of time. So the first one is sort of a broader macro level question, particularly around E2020 and some of the near elimination countries that are in the region. So James, with your E2020 hat on, how do you think this current pandemic is going to affect the E2020 targets in Asia Pacific? And sort of the more important question, I guess, is really how do we make sure we stay on track? What is the guidance to some of the E2020 countries, including Malaysia? Over to you,
Sure.
James.
Thank you. Thank you for the question, Amita. As we know, in the Western Pacific region, China, Malaysia, and Republic of Korea are part of this E2020 initiative. Really, the malaria programs from each of these countries have recently submitted a summary risk assessment and epidemiological update to WHO. Given an initial review of those assessments, it appears that COVID has had little negative effect or disruption on progress to achieving these targets. Efforts have been proceeding as scheduled as much as possible since the new year. Of course, Dr. Rose has briefed us all on Malaysia's efforts as part of the E2020 initiative. And it's clear that the program has done very well to manage the risk and has continued to report 0 indigenous cases this year. China as well has done well to maintain 0 indigenous cases this year. It plans to continue and go forward with its request to WHO for WHO certification of malaria-free status in June or July, as scheduled. Korea has maintained a similar number of cases as reported in Q1 last year and continues to implement essential malaria services unhindered for the most part. Of course, there are delays, some service delivery delays, but for the most part, we're seeing those move forward. Of course, there are many unknowns about COVID-19 and its potential impact on the E2020 targets in the future. To support countries to sort of stay on track, WHO is working very closely with the E2020 countries to collect evidence, to best update guidance, and to assist in the development of technical operational procedures for malaria interventions in the context of COVID-19. Also, WHO is closely monitoring the COVID situation in each country and the region, and it communicates frequently with the programs on potential bottlenecks and their planned mitigation strategies. Really, I think it's critical if countries are to stay on track. It obviously depends on the COVID situation and what we've been discussing throughout this hour, it's really just critical to maintain as much as possible the malaria services as scheduled. Of course, while modifying, as detailed by Dr. Rose, modifying operations on the ground as needed to maintain the infection prevention and control procedures, and shifting to sort of maybe using digital tools and virtual management tactics where feasible. I think it's really important to maintain strong essential malaria surveillance. This is critical. And this really to prevent the reintroduction of malaria in residual and non-active foci, while continuing to really test, treat, and follow up all cases, including those that are imported. And the countries, the E20 countries are doing this very well already. So it's just a matter, I think one of the biggest limitations may be this aspect of internal travel. But that is something that can be managed, and if healthcare workers are properly tested and carry travel documentation and have those approvals, then these essential services can be maintained.
Thank you, James. Before you go, a second question, and this is around vector control, and this is from the audience actually. So the question is, during the current COVID-19 situation, which has restricted global transportation and supply chain of malaria commodities, if there is a significant reduction in LLI and supply to countries, what would be the priority for BedNet coverage? Do you advise selective targeting via continuous distribution or mass campaigns in high burden areas? And what is the strategy for low burden areas?
Yeah. Okay, well, as of now, there is no reported shortage of LLINs in country. So this has not been disrupted in terms of global supply chain that we know about as of yet. So it's not an issue, an urgent issue, but of course planning is something that is important. And in terms of the current distribution, if you're talking about targeting, as I mentioned in the presentation already, I think countries will already have their stratification and distribution plans based on malaria burden. And really, as much as possible, to continue that schedule. The only exception that I think is worth considering might be this idea that in some very high densely populated urban areas where distributions are planned, although maybe those are lower burden in terms of malaria, to shift efforts more to the high burden areas in rural settings where there's less risk of person-to-person contact. And it's easier for the programs to maintain the infection control measures.
Thank you. So Dr. Nina, I think this theme of supply chain disruptions is obviously something that's front and center of everyone's minds, particularly within the programs, but also within the broader malaria community. We have heard of supply chain disruptions around commodities, whether it's diagnostic tests, medicines. What are some of the mitigating measures you think malaria programs can put in place to address these disruptions? And related to this is a question from the audience as well, which is specifically around the shortage of RDTs, especially in the GMS, which has a history of falciparum resistance. How can we ensure that there are certain areas that are prioritized? Is there some sort of an advocacy work that the malaria community can do to ensure supply of these RDTs to the right areas? I think it's a question around prioritization and what are some of the mechanisms that are in place to ensure that these areas get the commodities that they need. Dr. Nina, Dr. James.
Yeah. So thank you, Amita, for that. It's a definitely an issue of concern, and this is being discussed at all levels in WHO. So basically, when we talk about supplies, one is the global issue and other is the supplies within the country. So as far as a global perspective is concerned, definitely there has been some concern about the production of the medicines and RDTs, because the manufacturing sites in India and China, because of the lockdowns, there were some disruptions, and that's why this issue has been taken up at the highest level by WHO with the ministries, that these should be the essential activity, which should be continued, and now with the lockdowns now the countries being opened up, the things will be better. So that was that the supplies for future, they will be delayed, and whatever the global requirement is there, the supply can be delayed. and also like the some protective measures being used for the spray men and all because of the mask requirement being diverted for COVID. And in addition, one important thing that Abbott diverted its efforts from RDTs for malaria to COVID. So that all these things are definitely in radar and they are being taken up at highest level. And but at country level or otherwise, even if for global supply, the flight delays, the cargo, and all those issues are really worrying. And but that is for the next supplies. But as far as the countries are concerned, we have been in one-to-one conversation with them. So when we asked in our region also, they say that the supplies for some up to 2020 or next 6 to 8 months is fine with them. So within the country, of course, they had to see that wherever it is needed in which area that communication should be in place. And so for mitigation, one is the risk registries are being developed at HQ so that they know that what is the anticipated deficit and what could be the issues. The other thing is countries are being advised that they should, considering that there could be delay in the transportation, they should anticipate and see the stocks well in advance as compared to what they were doing earlier, so that they know if the supplies are needed and if the demand is more because of fever being a symptom in COVID. So then they should be acting much in advance rather than just before it is actually required. So the countries are also within their own systems are issuing guidelines and taking, and even for GMS, we had interaction recently with Myanmar and Thailand. So they say they have supplies for 2020, and as it is the country, the surveillance and other activities are going on fine, and both the countries have not been affected by COVID as much as the other countries. So things are in place as of now. But definitely one needs to be careful for the future supplies. Over.
Thank you. Thank you. So Dr. Rose, you laid out a really clear sort of case, I think, for flexibility, for adaptation in this unusual time. One question I had was, what are some of the innovative ways through which your national program has been able to continue keeping malaria services? And in addition to services, one question from the audience is, how has the Malaysian NMCP continued trainings for NMCP staff? One of your slides showed how you've moved a lot of your review meetings online. But in terms of training, and I think particularly the question is around malaria microscopy training, what's the plan B?
Yeah, thank you, Amita. I think it's a very good questions, because we also have discussed on that issue. And I think because we really have to depend on what are the government's decisions on the MCO. So if it's in the area where the enhanced MCO is being enforced, that we need to comply to the enforcements that was in that particular area. But we have divided the stratifications of the area based on the COVID-19 cases. So if it's a green area, they can continue with their trainings as usual. In the yellow area, where the cases happen, the locality where the cases happen, they will be doing it through virtual training. But where their area, there is a safe area, there's no COVID cases reported, they can conduct their training as usual. So we already have these clear guidelines in our what I have shared just now for the post-COVID, post-MCO COVID and malaria activities. So it is very important to actually to innovate and to think of different ways. So that's why we always harmonize our activity with the COVID-19 team. We always have discussions, and maybe we ask each other what will be the new methods that they are going to apply. So and we need to identify what are the critical actions that need to be done, that either in the red or in the yellow or in the green zone, they need to to do the critical activities. So in the critical activities, they have to do the activities, especially for the case area and the outbreak. And we modifications of the control measure is required based on the dynamic changes of the COVID SOP. And of course, on and off, we need to come out with administrative orders so that our ground staff will have a clear knowledge and methods what they have to do in that particular area. Yeah.
Thank you, Dr. Rose. So my next question is actually to Dr. Nina. Dr. Nina, as you know, APMEN is really a platform, and as you said at the beginning as well, what we really want to do is use the platform to showcase some of the best practices, some really stellar examples, I think, of what's worked and what hasn't. So keeping the COVID-19 situation in mind, are there any specific examples that come to mind, from within the region that you want to share with the broader community here?
Yes, Amita. So as I said, when we had discussions with each country one-to-one, and we were told that as of now, the surveillance activities and other activities are, despite postponing the LLI campaigns and IRS. But let me tell you, the countries which are like Bhutan and Timor, Timor did not have any indigenous case, and Bhutan is on verge of elimination. So these countries, fortunately, are not so much as of now affected by COVID. And but still, I would say that whatever cases they had, their health systems are activated fully, and especially for Bhutan. The health ministry issues the directives how to handle this situation, and last year only 3 cases were reported. And but one thing is that with the sealing of international borders, both for Timor and Bhutan, the imported cases across the border are not that many. But still, like Bhutan, we discussed that the temporary settlements, the people have been given bed nets there. And even in Timor, the people who were in quarantine or who had come across the border, the screening for malaria was done in all cases, and they found 1 or 2 positives as well. And in reference to the countries who already have eliminated malaria, like Sri Lanka, the surveillance, they investigated all the 9 imported cases very well, and they have all the information which has been shared. So for that matter, so as of now, and as I said, at the moment, they are not that much overwhelmed with the COVID, but the surveillance activity, there are smaller countries, surveillance activities and other things are going on, and we are even interacting with them for any further support. And even in countries with high burden like Indonesia, on World Malaria Day, they use that opportunity for advocacy and for training their medical officials and releasing the protocols for treatment of malaria and COVID. And they engage the regional office. And even I was really surprised to note they virtually distributed the certificates for subnational elimination also. So which is just encouraging those areas. So it is not that whole of the country is malaria endemic. There are few areas which are more prone to that. So accordingly, countries are doing their efforts and the activities depending on, as I said, COVID and their situation. But so far, at least for the countries near elimination, we are okay. Till date, the things are fine. Over.
Thank you. So Dr. Rose, the last question going to you really, which is, Malaysia's been a strong partner of APMEN right from the inception. This is really your community. So, given this current challenging situation with COVID-19 and malaria, if there were specific areas of support that you would like to request, what comes to mind? And currently, online we have partners who are from implementing agencies, from academia, from research, donors. So, what are some of the specific areas of support that you would welcome within the Ministry of Health?
Yes, I think in terms of from the malaria perspective, we still have, during the COVID pandemic, we still have this zoonotic malaria problems in our country. However, the number of cases is reducing. We are fortunate it's reducing. But in terms of way forward, I think we do require we welcome any collaborations with if there's any researchers that will can help us based on our program requirement or shortfalls, but that need to be discussed further with the relevant agencies, because we need to see what are the collaborations they can offer to us and what could we ask from the collaborator. But I think way forward, looking at this scenario in the COVID-19 pandemic, we need to apply the new normal in our malaria control activity and prevention, so that we need to educate our staff and also the public on the new normal that we are going to apply, because we know that this coronavirus is already in the community, and is the strains are so many. Then to wait for the coronavirus disappear from the community, I think it will take a long time, and we have to live with it, and we have to adopt and adjust our control measure.
Thank you, Dr. Rose. This is indeed the new normal, as you said, very wise. I think we're at the end of our time, so I just wanted to thank all of you, particularly the panelists, Dr. Nina, Dr. Rose, and James, who had to unfortunately leave early. But thank you to all our patient participants. We've had more than 110 participants, in this webinar. Looking forward to similar such collaborations going forward, and hope to see all of you on the next APMEN Exchange soon. Thank you.
Thank you, Amita. Thank you, colleagues.
Thank you, Amita. Thank you.
Bye. Bye.
Bye.